Well, thank you for coming back today. In the past, we've had people that didn't come back. I think when the classes we've had in the seminar room, it's always dicey. Whether people are overwhelmed, and that's most typically it's not people that are working in the business. You can take this class. Anybody can take the class and get a provisional certification. So, for example, if you have a student now that maybe the speech student would want to take the class, it's a very, I find it, it's an interesting class. And so the person signs up, takes the class, doesn't have the 500 hours, but can take a provisional test. It's the same exam, but they're provisionally certified until such time as they get the 500 hours. Now, it seems like a lot. I mean, we work 1,950 hours a week, a year, or something like that, 40 hours a week, say 2,000 hours. 500 is not all that much in terms of just your experience level and so forth. But so neurobehavioral assessment is huge. If people feel like they're ready to start, why? Because behavior is the outward measurement of activity and what we observe. So whenever I have a student with me, I always say, listen, I want you to, if anything you get from being here, I want you to be a better observer of behavior. That's it. Just be a better observer of behavior, and that will sustain you, at least initially, as you're training. So in doing so, you get better at being a diagnostician. If there's things that you're seeing that the physicians aren't seeing, we talked about that a little bit yesterday. I got a text last night about someone who is not sleeping, and can we give her 4 nights she hasn't slept? I said, well, I don't know, that's probably not the case. 4 nights you'd be pretty wiped out if you weren't sleeping. But so this nurse said, well, can we give her something for sleep? I said, well, we got to get Tirova on board. He is very reluctant to give anything of medication-wise for sleep. And if you, guys, if you mute your mics just so that we can be sure they're all muted. I also want to get wanted to make a recording if it was all right with you. Oh well. Caregiver education. We're constantly educating families, or were when they were allowed to come in, about X, Y, and Z, whatever our specialty might be, treatment planning and prognosis for the future. This is the Glasgow Coma scale that I tried to talk about yesterday. It's an observable behavior in eye opening, verbal responses, and any motor responses. Can they follow commands? Are they oriented to person, place, and time, situation, etc.? And can they open their eyes when you walk in? They spontaneously open, or they open only to speech, or you must induce some painful response for them to get them to open their eyes. I just wanted to show that because it's still utilized fairly frequently. Well, I mean, in the field, it's what the medics use to determine responsivity and what their next course of action might be. That you'll see this, you'll get a question on what is the Glasgow Coma scale. If someone has a Glasgow Coma scale of 14, they'll ask you at what point are they in terms of the continuum of a brain injury. Well, that would be a mild brain injury. If it's between 9 and 12, that's more moderate, and then below 8 is severe. The lowest you can get is no response to any of those 3 areas. No eye opening whatsoever, no motor responses to command, and no voicing at all. So 3 would be the lowest. And when you see that on the medic run sheets, it's a bad situation. And what's more, if there's abnormal flexion or extensor posturing at the scene, not good. So here are some coma assessment, consciousness assessment measures. I feel like I'm remembering that maybe Sam gave us an in-service on the Kennedy assessment tool. Maybe not, but in the past we've used the Kennedy. It's a tool. It's none of these. It's a tool that we use that is only done once a week. It's an assessment for someone that's in a either coma state or a minimally conscious state. These are other ones. A lot of them are probably downloadable and for free in the public domain. When I was in California working the Rancho scale, you've probably all heard about it. We still use it. It's a cognitive assessment, and it gives you a measure of where this person is in the continuum of returning from coma to community. So it really goes from either 1 to 8 or 1 to 10. There's some of the people that are an outpatient, you can rate them at a higher level, and they might be a Rancho 9 or Rancho 10 that's interactive. Most of us probably now are a Rancho 9 or 10, unless you stayed up late drinking. But these are some of the assessment tools. I'm not sure you're going to really get that. I hope it doesn't go into every single one in the coming slides, because it's a pain. So why do we want to rate disorders of consciousness? Well, one, and then most importantly, I think, is it helps us identify at what level the person is functioning. I'll just get those all up. Where they are right now in their continuum of arousal. So this is important. This is a reticular activating system. Someone has a coma, and what is coma? It's the absence of consciousness and the absence of responsivity, a person that does not respond. But we rate it because it's an objective measure that we can rate on and off again and again and again. It gives us some knowledge of where the patient is at this moment in that continuum. It helps us to provide some education to family members. It also gives us kind of the underlying likelihood of success or a good outcome. It's a predictor of outcomes, or in some cases, and it allows us to target certain behaviors. And on the right-hand side, like what medications, what complications we might experience, the sensory and motor involvement. Remember, some of these folks who are in a minimally conscious state, they do have some periods of wakefulness where their eyes might be open and they may be responding to you in your training. I'm sorry, in your work with the patient, whatever you're doing, and so we want to be on the lookout for that. And then it helps us derive some cognitive and communication domain with that person. Typically, if you've ever read any of my notes, I will say let's establish a yes/no response as quickly or as easily as simply as possible, and that might be something that's motoric, yes, no, and we do that. I know speech language does that as well too. So you have to establish some reliable measure of communication. Also helps us to set goals. We have to be mindful of the limitations of someone that's in a disorder of consciousness state. And so the traditional rehab on the left, you'd say you set functional skill goals, you work collaboratively, the individual is with you and an active participant, and the individual has some ability to direct his own care. That's the volitional control. Frequently I'm asked to do these kind of guardianship things, and the question comes down, or whether somebody is competent to make decisions. And a lot of times it comes down to this last one, volitional control. Are they able to participate and direct their own care? And somebody that is not competent is not participating and is not accurate, directing their own care in a viable way. And we could slice and dice that all morning, but that's what we look for. And then frequently you'll see the physicians, and I've done it before too, you invoke the healthcare proxy if someone is not able to participate in their own care adequately. So the person with the disorder of consciousness, though, has minimal responses. We treat based on their responses to stimuli. They typically do not participate directly. They typically are passive and may not be actively taking direction or listening to what you're teaching, and may not be even responding to your movements of their body in space. And they don't have that volitional control we talk about. Now, this is a big goal setting. I mean, I'm not going to read it all to you, but the goal type on the left-hand side, your goals are based on the responses that you're getting. So remember at the beginning we said, let's be better observers of behavior. And you have to carefully look at folks that have disorders of consciousness and observe accurately for some response to your active intervention with them. The problem is that families often, and when they would come in, they often see things that we might not see. And families will tell you that, well, he was eating the other day at the other hospital, and now he is minimally conscious. Well, if that was the case, then we'd be in trouble. But generally speaking, the families see things that are not necessarily accurate portrayals of that initiation and participation that we're looking for. How do they tolerate? We have a bad system here, a system that needs to be thoughtful. When we put somebody in a room, it shouldn't be the room where all the nurses are yammering away outside the door and laughing and talking about their days and what they're going to do after work. A patient should not be in a room where all those alarms are going off, because that is overstimulating. So depending on how well these folks respond and how they tolerate the stimulation of your therapy depends on, in a large part, where we put them, and there's an interaction between that overstimulation and their participation and their processing, the efficiency of their processing information. When you really need them most, if they're overstimulated, you're not going to get a good response. Risk management, that's as somebody is emerging from a disorder of consciousness, you have to be careful that they're not going to be in a situation that puts them at risk. Because remember, we wake up, we don't know where we are, and maybe the first thing you want to do is get out of this bed and go find out what's going on. And then caregiver development. That's sort of something that we do throughout the person's length of stay, and we must be very careful, respectful, and mindful about what they're feeling and how their life has changed with this person now in a minimally conscious state, and how overwhelming that can be. So again, if you look at some of the considerations and examples, it just means you need to provide education and be aware of some of the things we've just talked about. If a person can tolerate stimuli, say, for example, the tilt table, and we often start those folks at a very low angle on the tilt table and work our way up. You might start with 5 minutes of a 30-degree angle and then try to go for 10 minutes. Gradually increase that so they can tolerate greater and greater time out of bed and greater participation and upright mobility. So this really, the stimulation, the sensory stimulation is processed in the brain stem generally, and throughout the brain. As a person gets more aroused, and we talked about that dysautonomia, the autonomic storming yesterday. It comes up again in these slides, but we'll go through it. The reticular brain, the reticular activating system, is a great book called The Reticular Activating System. It really goes into overwhelming detail about the RAS, and it's about $200. So we want to make sure that we're stimulating someone in a controlled way. And that means that not everyone speak at once. If you're co-treating, it means not everybody touch the patient at once. It really requires some planned stimulation, and we do that before we go into the room. Generally speaking, it's best if one person do the talking, and the next day another person can do the talking. But so you want to really assess to what extent the person can regulate and participate in the session with you. Here are the sensory modalities. It's pretty, we know that. I'm not sure we do a good job assessing these things. I have a kit here that I use for sensory stimulation and for assessing these different modalities, these different sensory inputs. I'm not sure, and comment if you've ever done olfactory testing. You really have to, you can purchase kits that have different fragrances on them. When I have outpatients, I do the Pennsylvania smell identification test with them, because frequently, especially now with the coronavirus and the impact it has on olfaction, smell, the Pennsylvania smell identification test is an excellent one, and it we know that that olfactory system tends to be blunted in patients with Alzheimer's disease, and so we give it for outpatients if that's the question, whether or not they have a dementia. And so, and it's awesome because it's 40 items, 40 different fragrances. You scratch it, you sniff it, and you check off the one you think it is. Things like motor oil, lemon, blah blah blah, different smells. It's very good. So again, seeing, auditory input. Are they able to listen? And this is a wonderful. If you have patients that are in this, it's wonderful to use different modalities to get them to respond. A little bell you can use for hearing and stimulating the auditory input. Pre-recorded voices, maybe. Again, I'm sort of jumping around, but these are good, and we should be doing this when we have folks with disorder of consciousness. Now the thing is that we may have patients like this, and they quickly get better. They quickly, with our initial assessments, they will quickly improve. Usually coma itself lasts 1 to 2 weeks. If it goes much further, and we hear these stories of people in coma for months and months, then the likelihood of a successful outcome, meaning a functional outcome, it is limited. But in 1 to 2 weeks, they begin to transition to a higher level of care. Maybe they have some eye-opening and they're minimally conscious, and they have times of the day when they're more conscious and less conscious. And then after that, there's more of a steady arousal that you can work with. So we might not get folks that are at this level. They may go directly to either long-term care. They may go to one of the lower level brain injury programs. They may go out to Spalding and work with Brianna or Dr. J. Hefner is there. Maybe they work at Spalding with their program. So it really depends on a lot and how well we're equipped for them. But when we do, the next time we have somebody that's in a minimally conscious state, let's all work together with them at least once or twice and see how things look. And please, you've each had experience with this. Let me know what you've done in the past. If you've got a comment on that, rather than just we all do different work with folks, and yet when they come in with a lower level like that, we all have to do the same work, or we should do the same work to try to get the best. So Gus, yeah, yeah. How did it turn out? I mean, did she wind up going to a lower level of care? Did she get through that? Yeah. Was it a younger? Yeah. Yeah. Right. Yeah, that's a very good example. I mean, that sometimes our trials don't work if the person is not ready for that. I don't know why, gustatory taste. Why her taste would have been for all things, and so you know. Okay, well, thank you, Erica. So stimulation protocols, you should set up the environment ahead of time before you start doing this. Low distraction. It might not be best in the gym. You can. The problem is our rooms are so small here at times, or if there's two people in the room, my sense is they probably wouldn't do that now with people. But that you have to set up the environment so, one, learning can take place, so two, your examination can be accurate and reliable and valid, and three, that the patient gets the most from the time they get with you. And if they get 15 minutes because that's all they can tolerate, we want to maximize the utility of that time so that they get 15 minutes, not 6.5 and so forth. So you can see this for yourself. We have to go slow. The responses are very often infinitesimally long. They may vary depending on the stimulus and so forth. You don't want to overdo it with them. And here's how I try to put a behavioral plan in some of the charts. I don't like the current method that we have with the electronic medical record. I don't feel like it's all that useful, but we do want to record as much as possible the people's, their daily responses to our stimulating them, to our work efforts at stimulating them. And here's what as much as you'll do: no response at all, generalized response, or a localized response. And so you want to record that, and we can quantify it, and we can tell the family that they responded 3 times today, or 5 times today, or every time today when we've called them out. And this becomes part of the education, and the family members also will do a similar treatment if they wind up going home at some point. So I guess this is part of the complexity of our physical management. This is something that you all know and practice, and you've seen, and you've participated, and you co-taught. So this is pretty clear. Oops. I read this last night. Persons with disorders of consciousness offer professionals the unique opportunity to witness some of the most fascinating and inspirational recoveries in medicine. And when that happens, yes, that's true. But I feel like we don't often get those fascinating and inspirational recoveries. Because one, everything has changed. They're not with us long enough. And so we're seeing the slice of life in the 14 days they're here, or 18 days, or whatever we're giving them now. And I think we have to get better at advocating for longer lengths of stay, especially in folks that are in this disorder of consciousness. We've done this, I believe. So, or something like it. One of the other chapters has something on sleep. Let's just see what it brings us. Yeah, I will say this, and then I'll try to get to the next set of slides I wanted to show. Patients will universally say that they overestimate the amount of, they underestimate the amount of sleep they get. They underestimate. They will tell you in the morning, I didn't sleep a wink last night. And the staff will go in at 7 o'clock or 7:30, and the person will be eating their breakfast and say, not today, I didn't sleep a wink. And what I recommend, and this is what we started with, the nurse called and said, this person hasn't slept in 4 days. Well, okay, then perhaps they're tired. But we need to get better at really, at the night shift, watching and kind of assessing whether they're sleeping or not sleeping. If someone is sitting there with the television on for 6 hours, then yes, they're not sleeping. But generally speaking, people underestimate the number of hours. You say, how many hours did you sleep? Oh, 1 hour, only 1 hour. And then, but maybe it was 3 hours, maybe it was 4 hours, maybe it was 5 hours. And if they get 5 hours of sleep, say, listen, you're lucky. As you get older, the quality of sleep declines. As you get, every decade, it gets worse and worse. So that's just a take-home message about sleep. What we're going to try to do is get Dr. Tarova on board. What he will use a lot of times is melatonin. People that have poor sleep hygiene typically have already tried melatonin. Dr. Tarova is very reticent about prescribing a sleep medicine. I will say that no one should be on Ambien ever, and it probably should be taken off the market because there's a lot of somnambulism that goes along with people that are on Ambien. Somnambulism is our sleep disturbance where patients actually will awaken at night and have either night terrors or will wander around their home in a sleep, wakeful but sleep state. Their brains are still asleep, but their eyes are open and they're moving. It's very, very dangerous. People will fall downstairs. I've even had, and this is a true story, a man that was stopped by the police, and they called me to help. That he was stopped by in a state of somnambulism. He was driving his vehicle while asleep. So he didn't get very far, but and he did stop with a lot of siren and beeping of the horns. Woke him up and he pulled over, and so it was very, very scary for his wife. Seems like it's men that do that with the Ambien. Ambien is a hypnotic. It's in that's classification, and so it's as a hypnotic. It really does nothing to keep you asleep. It just puts you in that kind of hypnagogic state, and that if people complain of dreams, very bizarre, funky dreams, and night terrors, sleep disorder. They wake up when brains are still asleep. So, okay, this is the circle of circling the drain. People that complain of fatigue, they reduce their activity, then they get home and they're still tired, and they reduce it even further, and then the fatigue is so there's really, you have to enter this somewhere and tell the patient that, well, we've got to begin and start doing something some way. Okay. I don't feel like we need to go through all of this, so let me just back out of it. So this is the start of, are people all right with changing this? I mean, I feel like that we did covered sleep yesterday fairly aggressively and comprehensively. If you're interested in sleep, you can read the rest of that chapter. I think it's repetitive. But this is a big one, cognitive complications. Again, because they tend to be lingering, and they tend to be the most, have a significant impact on patients going forward after their injuries. So over 5 million people are disabled as a result of brain injury. How do we discern whether a person's cognitive impairment is going to be long-term or not? One. Two, how do we discern whether the person is disabled on the basis of that cognitive impairment or not? And whereas a lot of our patients are younger from car accidents or men falling off of roofs or people being assaulted, and more, it's difficult to say that one is going to be impaired cognitively for the rest of their lives. So, but it does bring up a lot of issues, and families deal with this all the time. And I love this: leading to increased caregiver burden and cost of care. So a lot of people come as an outpatient from their lawyers. The lawyers send them for neuropsychological or speech language pathology, along with physical restorative kinds of therapy needs. And they are looking for what the cost of care is going to be going forward. And that becomes part of the whole legal pursuit. So here are some of the elements of cognitive impairment. Those things you're well aware of: attention, concentration, short-term memory, working memory, and we'll go into some of these as we go along. Problem solving. Remember we talked about Megan going on a vacation, only $5,000. How do you solve that problem? Where do you go? What's where you get the most bang for the buck? Cruises are real cheap now, so if the spirit moves you, take a cruise. Decision making. These are all components, and they break down into complex pieces, different components of problem solving, different components of memory. Memory tends to be complex, and we'll go into that a little bit. So cognitive impairments certainly impact someone's quality of life and their ability to function independently, for these obvious reasons.